Yes. So let me first introduce today's speaker. It is Dr. George Rajivan Francis. He graduated from Jaffna Medical Faculty and then obtained his MD Medicine from University of Colombo. He underwent foreign training at Papworth Hospital in UK, and after returning from the foreign training, he has been working as a honorary consultant cardiologist at Teaching Hospital Batticalow, and he is also a senior lecturer at the senior lecturer in medicine at the Faculty of Health Sciences, Eastern University of Sri Lanka. His main interest is on social and cultural changes or reforms to promote cardiovascular health and prevent cardiovascular disease. Over to you, Dr. Rajivan.
Thank you, sir, for that kind introduction. So good evening, everyone. So we are going to have a look at a topic which is interesting and challenging at the same time, fluid and electrolyte balance. So let me first take you back to our basics. So life as we know it. So life on Earth is basically a water-based life form. And the life as we know it on Earth, it is dependent on maintaining a proper electrolyte and fluid balance, which is vital for all living organisms on Earth. Now, all life on Earth, including us, we evolved from single-cell organisms, which initially formed or were created in the ocean, the ancient oceans. Over time, from this unicellular organism, we have evolved and developed into more and more complex organisms such as ourselves. Now, this complexity, it started from unicellular organism, and as it slowly developed over time, each cell, it needed a way to get its nutrients and later on oxygen, as well as to remove its waste. In the initial times, when it was just unicellular organisms, the sea was there surrounding. But as time went by, there was a need to develop a specialized system, which is ultimately the cardiovascular system, which the ultimate goal of the cardiovascular system is going to form this fluid, which is going to be around the tissues. Now, if we look at each cell, this primordial sea, which was initially there around these unicellular organisms many billions of years ago, that same primordial sea still lies within each of us. If you look at the ionic makeup of the tissue fluid, which, as we know, all the extracellular fluid is mainly sodium, similar to the oceans. So blood plasma is actually regarded as a relic of the Paleozoic sea. And the ocean is the oldest fluid and electrolyte system in this world. So it's interesting when you think about it, that ancient sea is something which we are still carrying with us. And that is what we have to maintain for optimal health of our body, tissues, and cells. So as humans, we are still carrying this sea around with us. And it's important that we have this balance of electrolytes and fluid so that the functions can happen in an appropriate and correct manner. So now if you look at our body, the fluid is compartmentalized into certain compartments. We have our intracellular fluid, which is found within the cells, and you have the extracellular fluid. The extracellular fluid, again, is divided into two, which you have the interstitial fluid, which is the fluid that is found around all the cells. And then we have the plasma, or the intravascular fluid, which is going to be taking the oxygen and nutrients from the organs like the lungs and the gastrointestinal system to the cells, and the waste away from to the lungs and to the kidneys to remove the metabolic waste from the cells. Now, the composition of these compartments varies. So the volume or percentage of water that is found in each of these compartments is very tightly regulated. So how is this done? So each compartment of this in the body, the volume of water is actually going to be determined by the solute composition and the concentration at which these solids are found within each of these compartments. It's the osmotic forces which are going to keep this water molecules trapped in each compartment and maintain this correct balance. So therefore, it goes without saying that if there is a disturbance or imbalance in the solute composition or in the concentration of these solutes, then the volume of water that is found within each of these components is going to vary and going to cause problems to the organism as a whole. So if we look at the intracellular fluid, one of the most important factors that are going to maintain this fluid composition is the cell membrane. And in the cell membrane also is the sodium potassium ATPase pump, which is, in my opinion, the most important cellular uh, uh, pump or cellular organ in the body. So this pump or sodium potassium ATPase pump is going to maintain an imbalance between the sodium and the potassium ions. This will maintain an intracellular, so within the cells, there are high levels of proteins which are needed for various functions. So by maintaining this imbalance between the sodium and potassium ions, we are able, the cell is able to maintain a proper osmolarity. Otherwise, there will be hyposmolarity and fluid water will come in, and the cells will start to swell, which occurs in the initial stages of ischemia. Hypoxia, before necrosis happens, if you remember your pathophysiology, one of the first changes that happens is cells start to swell up. This swelling happens due to the loss of ATP in ischemia. So the cells are going to lose their function of the sodium potassium ATPase pump, and that is going to result in the cells starting to swell up, and then thereafter ischemia and death of the cells happen. If you look at the extracellular fluid, so the extracellular fluid, especially the tissue fluid that is found around the cells, are the immediate contact with the cells that are going to give the nutrients and remove the waste. The volume of extracellular fluid is going to be very tightly balanced. If there is an excessive volume of fluid, then it's going to cause edema, pressure on the organs, and reduce the tissue perfusion. The blood plasma is a transport mechanism. Now, the changes in this extracellular volume are going to depend mainly on the total body sodium content, especially the interstitial fluid volumes. So, by maintaining a proper sodium osmolarity and proper sodium concentration within the extracellular fluid, we are able to actually maintain this interstitial fluid at a proper level. So, this is just to make some basic understanding. So, let's now come to how is this clinically relevant. So when we are managing a patient, a critically ill patient in any setting, whenever we think about electrolyte and fluid balance, it's important for us to think about three things. What are the osmotic derangements that are happening in this patient? What are the electrolyte derangements? And how is the fluid distributed or mal-distributed in this patient? So these three aspects are critical for us to manage a bad patient. Proper understanding of these three factors will help in managing that particular patient. So when you take the plasma osmolarity, the normal range is tightly regulated between 275 to 295. Now, this is closely regulated by two mechanisms. One is the secretion of ADH and the thirst mechanism. So thirst mechanism will ensure that we are taking adequate amounts of water to maintain that particular osmolarity, and secretion of ADH will help remove excessive free water from the body. Thereby, it will maintain this plasma osmolarity. Now, why is it very important to maintain this optimal fluid environment? It is because each cell needs to have oxygen, nutrients, and each cell needs to have a way of removing the waste products from it. Now, this is done at the level of the capillaries through the tissue fluid formation. So this picture is something that we would have all learned during our physiology days of how the tissue fluid forms. But very few of us actually appreciate it until you really come to higher levels and when you really understand the cardiovascular physiology of how this beautiful mechanism of the heart and the arteries and the veins, the entire purpose is ultimately to form this optimal fluid environment for each and every cell in the body. So what are the factors that are going to affect this tissue fluid formation? If you remember, looking back to the previous picture, it is if the hydrostatic pressures are unbalanced. Like, for example, if the patient is having reduced cardiac output or reduced blood pressure, if there's reduced blood pressure, then at the arterial end of the capillary, there is going to be reduced tissue reduced capillary arterial pressure at the capillary end, and that is going to impair the tissue fluid formation. Similarly, if there is increased venous pressures, then that is again going to cause an imbalance in the hydrostatic pressure. The volume status, if there is inadequate volume, it goes without saying, tissue fluid cannot form. The oncotic pressures, so the oncotic pressure uh, uh, within the blood vessel, within the capillary, and the oncotic pressures in the tissues. So that balance is very important. If that balance is upset, then either the fluid might go too much to the interstitium, or the fluid might not go to the interstitial fluid and it will stay in the capillaries. So balancing these things, balancing these three factors, hydrostatic pressure, the volume status, and the oncotic pressures of the tissues is of the fluid is very important for us to optimize the fluid management of the patient. So how are you going to assess whether there is adequate tissue perfusion happening or not? So clinically, we can look at the skin color, temperature of the patient. Cold, clammy hands will indicate that there is reduction or reduced perfusion. Capillary refill, the pulse volume, sweating. Urinary output is a surrogate marker of cardiac output. We want to achieve a urine output of more than 0.5 milligrams per kilogram per hour. If there is a metabolic acidosis and lactate rising, then that tells us that the tissues are not getting oxygen, the cells are not getting oxygen. So therefore, the metabolism has now changed on to anaerobic metabolism. So this anaerobic metabolism is now producing lactate. So that's why there is now, so if we can improve that tissue perfusion, improve the oxygenation to the tissues, then that will be corrected. And of course, improvement or deterioration of any organ markers, liver functions, renal functions, whatever. So these are ways that we are going to clinically assess the patient. So always it's important that we keep an eye on whenever we have a critically ill patient. It's always important that we continuously monitor these parameters to see if the patient's tissue perfusion is adequate. Now, when you talk about management of intravascular volume, that is the volume that is found within the vascular tree. So there are things that are going to cause volume depletion and volume overload. So volume depletion will ultimately lead to hypotension, shock, and organ perfusion and things. If there is volume overload, then that like maybe over-aggressive fluid therapy, then this is again going to lead to impaired oxygen, edema, hypertension, organ congestion. So because there is now excessive interstitial fluid being formed, this excessive interstitial fluid is going to impair the oxygenation or impair the capillary perfusions for the organs. So it's important that we don't overhydrate the patient and we don't underhydrate the patient either. Optimal fluid balance. So this can be done by clinically always keeping a close eye on the volume status and how the patient is responding to any fluid challenges that we give. Now, if we come to the electrolyte balance, which is very important to balance. So having a proper electrolyte balance will help balance the tissue or fluid balance as well. In addition to other things like pH homeostasis and the other functions of neuromuscular, endocrine, and all of the organ functions also going to depend on these electrolyte balances. So if you look at the important electrolytes that we are going to talk about, they are sodium, potassium, calcium, and magnesium. So these four electrolytes are the key electrolytes which are going to affect the body's functions. So if you look at sodium, this is the commonest electrolyte abnormality that you will come across. And normally the sodium is well maintained by controlling both water intake and water excretion by the body. So water intake by thirst and water excretion by ADH. So normally it's in a range of the extracellular fluid, it's going to be 141 millimoles, around that range. And if you look at the intracellular fluid, it's at the other end, very low, 10 millimoles per liter. So this balance is key to maintaining the cellular functions. So let's just have a look at this small case here. So you have a 68-year-old woman who has severe aortic stenosis and heart failure with reduced ejection fraction. So she's admitted to the cardiac output, acute decompensation. She's hypotensive, tachypnic with signs of low output heart failure. She becomes progressively confused. So if you look at her lab results, we can see that her sodium is low, hyponatremic. Serum osmolality is also low. Urine osmolality is high. Urinary sodium is low, or within the normal, not too low, but this thing. Serum creatinine is 1.4, potassium is 4.7, serum cortisol, thyroid functions are normal. So now if you look at this patient, we can see that she's having reduced cardiac output. Obviously, aortic stenosis is there, reduced ejection fraction is there. So obviously, there is going to be reduced cardiac output here. So how is this reduced cardiac output going to result in hyponatremia in this patient? So if we can understand that, then we can think about what is the most appropriate initial management for her hyponatremia. Now, very often in our setup, whenever somebody sees a result of low sodium, like a knee-jerk reflex, people start the patients on oral salt or sodium chloride via NG tube or whatever. Now, is this going to be the appropriate management for this patient? Now, we said that sodium balance is going to depend on the water balance, so water excretion versus water intake. Now, she's becoming confused, 119, but still she's not having any convulsions or not in any acute state. So therefore, hypotonic saline is out. Now, okay. So if we see, if you look at the kidneys, so the kidneys are going to think that this patient is going to, it wants to keep more fluid and sodium water retention because there is going to be low cardiac output. At the same time, if you look at the center in the ADH center in the hypothalamus, it's also going to think that there is not enough fluid. So it wants to keep water. So it's going to secrete the antidiuretic ADH hormone, which is going to keep more and more water in the body. So here what we are going to do is we are going to begin fluid restriction and closely monitor the sodium levels of this patient. So that will slowly bring up her hyponatremia. So if we look at the next slide, we can understand that better. Hyponatremia. So serum sodium, it can be having like things like pseudo hyponatremia, where you have a normal osmolality with hyponatremia, or there can be actually hypotonic hyponatremia or hypertonic hyponatremia. Now this where you have this hypotonic hyponatremia. So this is where we are going to have this whether the patient is going to be hypovolemic or isovolemia or hypervolemic. So this can be differentiated by looking at the renal losses. If there is more than 20 millimole equivalent liters of fluid being lost by the kidneys, then we have to think of things like diuretics, adrenal insufficiency, and things. So wherever the patient's hypovolemic. But if the renal sodium is very low, like less than 10 milliequivalents, then it is more likely that there is some other loss happening. The kidneys are trying its best to keep the sodium in the body. Isovolumic, here it's going to be things like renal. Again, we look at the urine sodium. If the urine sodium is more than 20, the kidneys are not keeping the sodium in, like in renal failure. Or if the sodium is very low, then it's like primary polydipsia. Hypervolemia, so the patient is hypervolemic. The body is trying to keep excessive water, but there is not enough. There is too much of water compared to the salt in the body. So that is typically here, like in cardiac failure, if we check the urine sodium, it's going to be less than 10 millimoles per liter. Now, this is a little bit of a busy slide, but we can go through little by little. So the top part is basically the same thing. Now, if we come to the treatment. So if we come to the treatment, so if the patient is having hypovolemic hypernatremia, that is total body water is also low, total sodium is also low, then we are going to, if it's an acute hyponatremia, then you will want to go with 3% sodium chloride or hypertonic saline. If it's chronic, then we'll want to slowly replace the salt by 0.9% sodium and slowly correct the fluid and sodium deficiency. Now, when you have hypervolemic hyponatremia, like in cardiac failure, so here it's going to be usually like a chronic thing, where initially our management is going to be fluid restriction, as we decided for that particular patient. With acute, of course, acute hyponatremia, then we can think of giving hypertonic saline to correct that hyponatremia. Euvolemic patients, again, it's going to be fluid restriction and treating any underlying causes. Right. So let's just come to another case here. We have a 74-year-old male patient with a history of ischemic cardiomyopathy. Ejection fraction again is low and having atrial fibrillation, CKD stage 3, admitted to the cardiac ICU with acute decompensated heart failure. Again, heart failure. He is intubated, sedated, has a nasogastric tube, but no enteral feeds started yet. On day 3 of admission, we can see, if you look at the abnormalities, his sodium is high, serum osmolality is high, urine osmolality is in the normal range, serum creatinine is baseline, just above normal. So what may be the likely cause of his hyponatremia here? So here we have to think of our balance. So in the previous patient, there was the ADH was going on. Here, there is not. So if you look at our answers, central diabetes insipidus, excessive sodium load from IV fluids, which is possible sometimes, maybe. Fluid loss due to insensible loss and inadequate replacement. So here, most likely, so the patient is having an nasogastric fluid, but no feeding has yet started. So the free water is going to be lost from this patient. So as there is free water loss, the patient is going to become hypernatremic. So here our treatment is going to be, we are going to try to replace the patient's free water levels. So hypernatremia, sorry. So this is defined as any or sodium level of more than 145 millimoles per liter. And this occurs when thirst or access to water is impaired. That is the most important reason. Usually it's going to affect extreme ages, and in adult patients, it can be symptomatic, can become symptomatic if the sodium level exceeds 160 millimoles per liter and lead to brain shrinkage, which can thereafter lead to ICH and intracranial hemorrhages happening. So if you look at these patients, if you look at the volume status and the etiology and things, so you can see if the patient is hypervolemic hypernatremia, so then it's going to be loss of water, which is more than the loss of sodium. So it's called loss of sodium and loss of water happening, but the loss of water is more than that. So this will lead to a deficiency of hypertonic fluids. So if you replace the hypertonic fluids, so for example, the patient is having some GI loss, sweating. So yeah. Then you have high euvolemic hypernatremia. So euvolemic hypernatremia, there the patient is going to have pure water loss. Normal, yes. Can everyone mute your? Thank you. Okay, right. So here there is going to be low sodium with reduced total body water. So typically, like diabetes insipidus or fevers, or when there's excessive respiratory loss, like if the patient is tachypneic, then there can be water being lost with expiration. So these can lead to euvolemic hypernatremia. So we take hypervolemic hypernatremia. Here, excessive sodium gain. For some reason, there is salt is staying in the body more than the water. So typically, it may be iatrogenic, like if you give excessive or too much of hypertonic saline, or it can be also due to certain endocrine related conditions like Cushing syndrome and concept. So the management is going to be, again, it's going to depend on whether this is acute or chronic. If it's an acute hypernatremia, that is when the hypernatremia is less than 24 hours, then we want to correct the sodium, uh, serum sodium at usually at a rate of around 2 to 3 millimoles per liter per hour. So how are we going to do that? We are going to give the patient some hypotonic fluids or free water like 5% dextrose, or if we can consider even more hypotonic infusates, but they should be given at a slower rate and with more close monitoring. It's very important that we don't overcorrect, because excessive correction of hyponatremia or rapid correction can lead to serious neurological issues. Now, with chronic hyponatremia, also we should correct it, but we should be very, very careful, and we should not exceed a rate of more than 0.5 millimoles per liter. Uh, so, serum electrolytes should be again closely monitored. The management is going to be in a similar way. It's just that the rapidity of management is going to differ. The other important electrolyte that we talk about in the body is going to be potassium. So it is essential for all body systems, potassium. 98% of the potassium in the body is located intracellularly. It is the major cation within the cells, and that is going to be the major determinant of the resting membrane across the resting potential also within the cell membrane. So abnormalities in potassium can lead to death and due to cardiac arrest or respiratory arrest or both. So you can see the extracellular fluid has a very small amount of potassium compared to the intracellular fluid. So let's just take this small case again. So you have a patient, a 69-year-old male with a history of chronic heart failure and reduced ejection fraction, chronic kidney disease stage 4 and hypertension, administered with worsening dyspnea. The patient is on some medications like enalapril, spironolactone. She's on some furosemide as well and carvedilol. Hemodynamically stable. There is no evidence of acute volume overload. But if you look at the potassium, it's 6.6 peaked waves. So the patient is on enalapril, spironolactone, both of which could have pushed up the potassium levels. On top of that, the patient is having stage 4 CKD. Look at the arterial pH, it's marginally towards the acidotic side. So what are we going to do? So here we want to bring down the potassium, that's correct. So we know that spironolactone, enalapril may have pushed up the potassium, but here it's very, very important because we have ECG changes. The patient is at risk of developing lethal cardiac arrhythmias at any time. So therefore, before we initiate the definitive corrective management to bring down the potassium levels, we have to administer IV calcium gluconate as a membrane stabilizer. So this will stabilize the cardiac membranes until the other things can be done, like maybe dextrosinsulin or whatever, to bring down the potassium levels. So hyperkalemia. So hyperkalemia is defined as a serum potassium of more than 5.5 and commonly seen in many disease conditions. Mild, we can classify hyperkalemia as mild, moderate, and severe. And the clinical presentation can vary, can may be asymptomatic or may actually going to cardiac arrest and death. Now, the pH balance is very, very important. If the patient is acidotic, then the serum, so you look at this graph, you can see that acidosis tends to push the potassium out of the cells, and that is going to increase uh, serum uh, serum potassium levels. Similarly, alkalosis is going to send more potassium into the cells, and that is going to bring down the serum potassium levels. So having a correct pH balance is also very important when we talk about potassium balance. So these ECG changes, it varies from just initial tall tented T waves up to the sine wave. So the sine wave is a peri-arrest wave. The patient can arrest at any minute. So when the patient is having a sine wave and when we give calcium gluconate for the patient, as we monitor the serum, the ECG on the cardiac monitor, very nicely we can see that the sine wave will narrow down and the patient will become come into normal, beautiful, narrow QRS complexes. But as you monitor, maybe about 20-30 minutes later, again, slowly, this wave is going to start to broaden out and the patient will start to develop this sine wave again. So it's important that we keep the patient on close cardiac monitoring and continuous ECG monitoring, and thereby give the calcium gluconate whenever the patient goes into this sine wave pattern or whenever ECG changes start to develop, while we are doing our concurrent management to bring down the potassium levels. It's not you just give calcium gluconate once and forget about it. Repeated doses may be needed until you bring down the potassium level for this patient. So when you take the emergency management, if there are ECG changes or if there are no ECG changes, if there are ECG changes, then the first management is going to be to give calcium gluconate, then do some management to shift the potassium into the cells or remove the potassium from the body. If there is no ECG changes, then we don't need to give calcium gluconate. We can directly go to mechanisms by which we remove the potassium from the body or shift the potassium into the cells. So the time-tested way is to give insulin with dextrose. So that is again going to work through our sodium-potassium ATPase pump and with the sodium insulin exchanger, which will work by the sodium-potassium ATPase pump, and it will bring the potassium levels down. One interesting thing to remember when you're managing a patient with hyperkalemia and low blood pressure, low doses of epinephrine will also help to bring down the plasma potassium in patients, and also it will help with inotropic support. So remember, if you're having a patient with high potassium and low blood pressure, epinephrine is going to be your drug of choice there. Right, so let's just look at another small case. Here we have a 64-year-old woman. 64-year-old woman who has a history of hypertension, paroxysmal atrial fibrillation, and recent anterior STEMI, who is managed with PCI and being monitored in the CCU. She is now on these medications, which includes metoprolol, furosemide, clopidogrel, aspirin, atorvastatin, and pantoprazole. Now on day 3, she's starting to develop some palpitations, lightheadedness, ECG showing multiple runs of some ectopy and some non-sustained VT. We are doing the electrolytes, it's showing a potassium of 2.9. Magnesium is also towards the low side of normal. So what is the most appropriate step here? So here we are having a patient with a low serum potassium with ECG changes. Again, this is a lethal combination. The patient can go into cardiac arrest any time. So it's very important that we rapidly correct the potassium levels. Now, again, a mistake that many of people do is just start oral KCL, 2 tablets, TDS or whatever, which is going to be useless. Here, it's important that we decide to administer IV potassium chloride to the patient. It is actually quite safe as long as you give it at a slow infusion rate, not exceeding 20 millimoles per liter over 4 hours. So, and that will slowly bring up the potassium in a safe manner. Oral magnesium supplementation is also mentioned here. Now, whenever a patient is having hypomagnesemia, it's very difficult for us to correct the potassium. So therefore, whenever you have a patient with hypokalemia, it's important that we look at the magnesium level and correct that as well. Otherwise, the kidneys will keep on excreting the potassium and we will not be able to correct the potassium levels in the patient. So that is something to remember. Right. So hypokalemia, again defined as a potassium level of less than 3.5, life-threatening if the potassium is less than 2.5. Again, we can classify as mild, moderate, and severe hypokalemia. So hypokalemia, we have some ECG changes that we'll be looking at. We have a prominent U waves, and also you can have this flattening of the T wave and some descending of the ST segment. So these are changes that you will see with hypokalemia. So causes of hypokalemia, again, it's going to be either due to poor intake, excessive losses. So losses may be either renal losses or extrarenal losses, or it may be a transcellular shift, which is sending the potassium, too much of potassium is going into the cells, and that is leading to hypokalemia in the serum. So our treatment goal is going to be to prevent any further potassium loss, replenish the potassium stores, and treat the underlying causes. So intravenous potassium should be administered very slowly, and our goal is going to be to bring the potassium up to around 3.5, above 3.5. That's the serum potassium. So how can IV potassium be given? We administer it at a rate of less than 8 millimoles per hour through a peripheral line, or we can go a little bit more if you are using a central line. Potassium, the total body potassium that is needed can be calculated using this formula, where you have the potassium in millimoles, which is going to equal the normal lower level, which is 3.5 minus the measured level into the body weight into 0.4. So this is an approximation which can be used in patients for us to know how much of potassium we want to give for the patient. So this is the deficiency, the potassium deficit. In addition to this, we have to consider what is the daily requirement of potassium as well, which is usually 1 millimole per kilogram body weight. So if the patient is 50 kilograms, we should think of adding to this potassium deficit 50 millimoles of potassium as well. We don't have to give everything, but this is just a rough guide for us to have an idea of how much of potassium we actually have to give. So as I said previously as well, magnesium should be corrected as well if we want to correct hypokalemia. So if you look at the magnesium hemostasis, magnesium is again an important electrolyte for both neuromuscular stability and muscle contractions. Again, it's closely regulated. And the hemostasis is going to be through the GI tract, bone, and kidneys. So hypomagnesemia is again defined as a magnesium level of less than 1.8. Anything less than 1.2 is going to cause symptoms. The worst symptom or worst manifestation that we see with hypomagnesemia is this Tosa-Dupont type of ECG that you can see on the bottom. So if the patient is developing seizures, or if the patient is developing ECG abnormalities like Tosa, then it's important that we rapidly correct this magnesium. So we will load the patient with 2 grams of magnesium sulfate over 5 to 15 minutes, followed by another 2 grams additionally for over 30 to 60 minutes. And then we want to give a continuous infusion of magnesium sulfate, 1 gram per hour, and we will continuously or repeatedly monitor the electrolyte levels, and then we will stop or reduce the when we reach 5 to 7 milligram per deciliter. So this is how it's not just to give 1 bolus magnesium and stop. We have to give repeatedly, and we have to correct it adequately if you want to stop the seizures and the ECG changes. Hypermagnesemia, again, hypermagnesemia is when you have excessive magnesium levels of more than 2.6. Patients can have confusion, lethargy, respiratory distress, respiratory weakness. So typically this occurs if we go and excessively give magnesium. So it is usually iatrogenic. So here we want to give IV calcium gluconate to stabilize the myocardium, and we want to do something to remove the excessive magnesium from the body, which can be either through diuresis or dialysis. Now let's come to calcium. So if you look at the calcium, calcium is mainly found in the bone of the body. Only a very tiny portion is located in the plasma. Now, if of that tiny portion also, a large volume, almost 40% is bound to, or more than 40% is bound to albumin. Only around 50% is in the ionized form. And this is the most important uh, moiety of calcium that we want to look at. So therefore, ionized calcium is the best measurement. If we cannot check ionized calcium, so those days we used to do corrected calcium levels. So now most labs are able to give us the ionized calcium level directly. So that need for corrected calcium for albumin is usually now less in most of our labs. So if you look at hypocalcemia, so important things that we are going to see is the patient may be irritable. There may be spasms like tetany, Crozier sign may be positive, and also the patient may have hypotension. Especially when you're having a patient on inotropes, and if the patient is not responding to inotropes. Remember, there are two important things to think about. One is the patient acidotic? Acidosis is not going to allow the inotropes to work. Number two is this patient hypocalcemic? If the patient is hypocalcemic, again, inotropes are not going to work. So correcting hypocalcemia is very important when you have a patient with who is critically ill on inotropes and the inotropes are not responding. So treatment of hypocalcemia, again, it is to administer calcium gluconate, which can be administered through the protocol that is mentioned here. Remember, we have to give boluses followed by continuous infusions. It is not just giving once and forgetting about the patient. It is about repeatedly giving and repeatedly monitoring and repeatedly correcting. Then let's come to hypercalcemia. So hypercalcemia very often is due to malignancies like multiple myeloma or when you have some bone metastasis. So here the patient is going to have the typical mnemonic of bones, stones, groans, and psychic moans. So if you look at the ECG changes, there will be this shortening of the QT segment. Symptomatic hypercalcemia, it's again is going to require some rapid correction, especially with rehydration. You want to rehydrate the patient, give adequate fluids, brisk diuresis sometimes may also be needed. So in addition to this, we can give bisphosphonates, IV if available, and then hemodialysis also important. So as I mentioned previously, about 90% of hypercalcemia due to either malignancy and also hyperparathyroidism. Hyperparathyroidism is anyway rather a rare condition. Most of the hypercalcemia that we see in clinical practice is mostly due to malignancies. Right. So therefore, in conclusion regarding our electrolyte balances, appropriate fluid management in critically ill patients is a very challenging and very important for intensive care. Remember, so we should sufficiently fluid resuscitate the patient. At the same time, we should maintain a proper balance without overly giving too much of fluid either. So it's important that we think about both hemodynamic stability as well as improving tissue oxygenation. Almost all critically ill patients are going to have some electrolyte abnormality. So it's important that we look into what this electrolyte abnormality is and correct it accordingly. So depletion of overabundance of these four important electrolytes that I spoke about can be caused by various clinical conditions and various outcomes. So therefore, depending on the patient that you're managing, look at these things. So the last take-home thought is, remember the primordial C. Remember that each cell in the body needs to have a proper tissue fluid. So whatever you do, whatever management that you initiate, think that, am I able to give the cells that primordial C? Am I able to produce that primordial C for the cells? So that is going to be by seeing that there is proper interstitial fluid happening. So for us to have proper interstitial fluid happening, we need to have proper organ perfusion. So proper blood pressure, adequate blood pressure for capillary, for the tissue fluid to form at the capillary levels, proper venous drainage, proper oncotic pressures within the plasma and in the tissues. So all of these things should be thought about, with our ultimate goal is to ensure that each and every cell, so as if each cell gets the adequate metabolites, adequate nutrients, and is able to send out its waste, then as each cell functions properly, the organ will function properly, and as the organ functions properly, the individual or the patient will survive the critically ill phase. So thank you very much for your listening, and I think we have some time for any questions that I'll be very happy to answer.
Thank you, Rajivan, for that excellent lecture. Yes, we have time. So anyone wants to ask a question, either you can unmute yourself and ask, or you can put it in the chat also.
Any challenges that you all faced at any time? So real learning comes through discussion. Right. Okay, so we have one question. How frequently can we administer IV calcium gluconate to manage hyperkalemia? Right, so very good question. So very often one mistake that we see happening in the general medical wards and surgical wards is, people immediately when you see hyperkalemia, whether there is ECG changes or not, it's like a knee reflex. People give the calcium gluconate, 10 ml, 10% calcium gluconate immediately given. But thereafter, everybody forgets about it. So just that single dose of calcium gluconate is not going to be enough, or not going to give you enough time to bring down the potassium level. So this calcium gluconate is not going to bring down the potassium in any way. It's only going to buy you time so that you can do some other method, or maybe dextrose insulin or dialysis or whatever, to bring down the potassium levels. So therefore, it's very important to keep the patient, as I said, on continuous ECG monitoring. And if you see the ECG, so people who have seen that will understand, when you see the sine wave happening, as you give this calcium gluconate, as the infusion goes, very beautifully, that wave that is going up and down and up and down and looking very horrible, nicely comes, narrows down, and you get the beautiful PQRST pattern. But as I said, about 20-30 minutes later, again slowly this starts to widen out, the T starts to go up, and the sine wave starts to develop. So if that happens, again you have to give. Now there's no limit to how many times you're going to give, but usually by the third time, so usually you might have to give a repeated dose of calcium gluconate in 30 minutes time. So 30 minutes, so 30 minutes and 30 minutes. So by the third dose, usually by that time, you would have been able to bring down the potassium level to a manageable or a non-lethal level using other methods by 1.5 hours. So to answer your question, how frequently, there is no limit there, but obviously if you keep on giving calcium gluconate, you're going to cause hypercalcemia, which causes other problems and which you have to manage. But to prevent this death of due to hyperkalemia, you can give, but usually around 3 times will be enough. You don't have to administer more than that. You would be able to bring down the potassium to manageable levels by that time. So I hope I answered that.
Yes. Any other questions?
You're welcome. When there is significant hyperkalemia, if we are giving calcium gluconate as the initial management without doing an ECG, will there be a problem? No, there won't be a problem as such. There won't be a problem, but now I don't know what is the excuse for not connecting the patient to a ECG or monitor in our current setup. Every ward, uh, I don't think there's a ward in the hospital that does not have an ECG monitor, whether it's surgical, general ops, pediatric, whatever. So, uh, but there is no problem. If if you're suspecting the patient is having hyperkalemia, sorry, if you have the patient is having hyperkalemia and you don't have the facility to do an ECG immediately, or you cannot connect the patient to an ECG monitor immediately, no issues. Give calcium gluconate, that will save the patient's life.
So, yes.
Okay, thank you. Yeah, anything else? So patients that you all would have come across, problems that you all would have come across. So magnesium. So as I mentioned, so very often sometimes we get patients with VT. VT keeps on coming. We give amiodarone and things. But remember to check the magnesium level. So magnesium, if the patient is hypomagnesiemic, then it's very difficult to control that VT without correcting the magnesium level. So few things to remember.
Yes, I think that is one of the common issues that we have. And Rajivan, if I may ask, in the
Yes,
nights, if the magnesium is not possible to do, we
yes,
sometimes empirically give IV magnesium. Is that a
yes,
correct practice?
yeah, yes. I mean, that is that is something that we have to do. We also do that, sir.
Yes,
Very
yes,
often we can't get the magnesium during the night time. It's done only the day
yes.
labs. So we give magnesium. So there is almost always the patients are going to be hypomagnesiemic and these things. So,
Thank you.
uh,
I think, yes, in the absence of questions, we will conclude the lecture. Thank you very much, Dr. Rajivan, for that excellent lecture. Hope you will continue to support the program in the coming years as well.
thank you, sir. Sure.
Thank you, and good night.